Excellencies, ladies and gentlemen, dear colleagues, I wish to thank the Prison Health and Rights Consortium for inviting me to speak at today's side event through this recorded video message. I'm encouraged by the efforts that many states have taken to provide harm reduction services to persons deprived of liberty. However, taking into consideration the structural problems in prison systems in some countries, I remain concerned that many states continue to either discriminate in provision of harm reduction services to prisons or refuse to pursue a harm reduction approach for society at large. On this 75th anniversary of the signing of the Universal Declaration of Human Rights, we must strive to ensure people deprived of their liberty access to medical health care, including preventative care with no discrimination. I call on the states that have not yet ratified the International Covenant on Economic, Social, and Cultural Rights to do so. Vulnerable groups of the population and marginalized persons should be at the center of the harm reduction policies, and these policies should be implemented being mindful of the specific situation of the persons deprived of their liberty. The continuance of the war on drugs has a particular negative impact on people deprived of liberty, who are often first forced into rehabilitation or deprived of essential medical care. In this regard, medical considerations should prevail over security or punitive aspects, in particular when people need specific medical treatment, including people affected by HIV. The international guidelines on human rights and drug policy have called on states to ensure the availability and accessibility of harm reduction services for vulnerable groups, and people deprived of liberty, an exceptionally vulnerable group who must be given care that is tailored to their individual needs to fully implement their right to physical and mental health. First, in keeping to the harm reduction approach, treatment for drug dependence must be entirely voluntary. Choice between prison and rehabilitation is not consistent with the right to choose one's own medical care. States must end this practice. In similar vein, states sometimes withhold medical treatment, including opiate substitution therapy, for people who use drugs in an attempt to force a confession. This could amount to torture or inhumane or cruel treatment. Excellencies and colleagues, healthcare policies for people who use drugs in prisons and detention facilities must be designed with harm reduction in mind. I reiterate that harm reduction health services must be offered on a voluntary basis and must be tailored to the specific situation of the detainee from an intersectional approach. Furthermore, medical practitioners should be independent from the staff working in prisons. One method of healthcare-related harm reduction that is not broadly available to people deprived of liberty is opiate substitution therapy, OST. While 86 countries offer OST programs, OST was only available in 56 countries in places of detention. Opioid substitution therapy is an evidence-based that is consistent with the harm reduction strategy, and providing medications such as methadone and buprenorphine can be essential for some dependents to reduce their addiction to opioids. OST reduces the prevalence of injection of opioids and needle sharing, thus reducing the likelihood of contracting blood-borne diseases such as HIV. Needle and syringe programs are another aspect of harm reduction health approach that states must take and make available for people who use drugs. Currently, needle and syringe programs are available in 98 countries, but only 11 countries provide these services in places of detention. States should offer other crucial components of harm reduction in prison, such as education programs designed to minimize harm for people who use drugs. In addition, states must make a concerted effort to end gender-based discrimination in the provision of harm reduction services. This continues to be a serious problem in detention facilities, particularly in case of opioid substitution therapy, where some countries only make it available in male prisons. In many countries, migrants in detention centers receive no access to harm reduction programs. I encourage states to follow good examples which make some of these services available to migrants in detention. Some examples from Georgia, Cyprus, Italy, and Lebanon. Finally, harm reduction services for other vulnerable people deprived of liberty, such as children, LGBTQI+ people, people with disabilities, and older persons, should also be made available, taking consideration of their specific needs. Excellencies, in concluding, I urge states to make a concerted effort to ensure that harm reduction services are fully available to people deprived of liberty without discrimination, and to leave no one behind, including persons who use drugs and any affected community. It is time to make special efforts to provide public services and support to people who use drugs and communities that have been harmed by the so-called war on drugs. The war on drugs is but a war on people. It is time to change this paradigm shift and the overall goals of drug policies to ensure that they are aligned with the Sustainable Development Agenda and the Human Rights Agenda, as well as the obligations and spirit under the Universal Declaration on Human Rights. Thank you.